Screen, Anna?
Yes, okay. So welcome everyone and to this webinar where we are going to share some knowledge about chronic pelvic pain. And I also would like to thank NovoCare for inviting me to do this presentation. I hope you enjoy the presentation and I hope you can have a little bit of idea of the work that we are doing in our practice. And also our experience with the diagnosis and treatments, also with the Maple in chronic pelvic pain. So I'm working with Maple for 7 years now, and I have been doing also some research. I have a pelvic physiotherapist practice in the Netherlands, so I'm an owner of Pelvic Centrum. And I'm also co-author of the Dutch multidisciplinary guideline for chronic pelvic pain that was published in 2021. And I'm a member of the scientific committee of the Dutch Association for Pelvic Physiotherapy. So today we are going to see a little bit, I have an overview plan. So we are going to talk a little bit about anatomy and innervation of the pelvic and pelvic floor area. Then we are going to start with chronic pelvic pain, the definition, risk assessments, and role of the pelvic physiotherapy. I'm also presenting a case study, and I'm going to talk about biofeedback in electrical stimulation with Maple in chronic pelvic pain. And at the end, a little bit of a take-home message. And if there are questions, Jel said to everyone just a couple of minutes ago. So please do the questions on the chat, and then we will check them later. And you will see a proper response from me or from NovoCare regarding to your questions. So let's start to talk a little bit about the pelvis. As everyone knows, it consists of a ring formed by 3 bone pieces, the os, ilium, and the sacrum. And the ilium are held together by very strong ligaments. So actually, it is important to realize that these structures are very strong. And for example, the sacrotuberosal ligament can withstand a load of 150 kilos without tearing off. So the lower 2 lumbar vertebrae are also connected with the pelvis by ligaments, and the sacrum forms on the back part the IC joints, and at the front the pubic symphysis. The form closure of the stability of the pelvis is given by the form closure, so the shape of the joint surface, and the shape of these joints varies from individual to individual. In other end, it's also the stability is given by the force closure, and that's the ligaments, muscles, and tendon plates. As we talk about the force closure of the pelvis, we can think about the local stabilizers. And the local stabilizers actually will refer to the collaboration of the muscles in this cylinder. So on the upper side, we have the diaphragm. On the lower side, we have the pelvic floor. On the front side, we have the transversus abdominis, and on the back side, the multifidus. And this is actually what I also explain to the patient when it comes to our practice. So when there is chronic pelvic pain, it can be also this balance in the constant cooperation between these muscle groups. So that means that a complaint in the pelvis, abdomen, and lumbar spine can lead to a complaint in the pelvic floor and vice versa. So still talking about the anatomy, we cannot forget that the pelvic floor doesn't work alone, as mentioned in the previous slide. So we need to look a little bit more generally to the patient, and we know that when we see sometimes a higher tone in the pelvic floor, we can find also this higher tone in other muscles. And these muscles are frequently the quadratus lumborum, the rectus abdominis, the psoas iliacus, and also the adductor of the upper leg. So that means that when you are seeing a patient with chronic pelvic pain, don't focus only on the pelvic floor, but we try to see also the muscles around, because if we only focus on the pelvic floor, we may overlook important factors in the patient's condition, which can impact the therapy outcome. So here we can see an overview of the pelvic floor. Yes? Oh, can I continue? I think so. So here we can see the anatomy of the pelvic floor, and we see different layers, different muscles. And in red, we can actually see the muscles that we later will be able to evaluate with a maple.
Anna?
Yes?
Sorry to interrupt. There's
Yes?
a gray block at the bottom center of your presentation. I'm not sure if that is also in your view.
No?
Is it only in my view, perhaps?
I don't know. Maybe someone can...
I see it as well.
Okay.
A gray
Anna,
block.
Yeah,
Yes?
can you maybe minimize your presentation and then enlarge it again? Is that possible?
Yes, let me try. And is this since the beginning or?
Yeah, now I think you're not sharing anymore, right?
No, I'm going to start again.
Yes, now it's gone. Perfect.
Oh no, it's
Thank you.
gone. And can I continue or should I get back?
I think you can continue.
Okay. So we now can see the innervation of the pelvic floor. And the innervation of the pelvic floor is actually done by the sacral plexus. And the nerve levator ani that we see in yellow in the image innervates the proximal parts of the pelvic floor musculature. And the pudendal nerve, the green in the image, innervates the distal superficial parts of the pelvic floor musculature. But it is still not completely clear which parts belong to the pudendal nerve and which parts belong to the levator ani. So because there is an overlap between the nerves and also some individual differences. Also regarding to the innervation, it is important to understand that the organization of the motor neurons in the pelvic floor musculature is different from the ones in the limbs. The motor neurons on both sides must work together to allow the pelvic floor musculature to function as a unified unit. And it appears that it's not possible to selectively contract the right or the left half of the pelvic floor. However, the unilateral innervation does lead to differences in activation patterns, and that we can see observing with the MG. So that actually we see a lot with maple, that not every time the activity is the same on the left and on the right side. So starting a little bit about the chronic pelvic pain, I am going to talk about the definition that we used on the guideline in the Netherlands. So we defined as chronic pelvic pain that is pain felt in the lower abdomen, pelvic and pelvic floor area that lasts for more than 6 months or recurs periodically. This pain is often accompanied by symptoms related to urination, bowel movements, menstruation, and sexuality, and also typically affects one's overall well-being and interpersonal relationships, both at home and at work. So this is a little bit the patient that we get on the practice. Also talking about the risk assessment of these patients is really important because this can be helpful in planning the care trajectory. On the literature, we identify some characteristics of the complaints and also from the patients that may indicate a higher risk of developing chronic pelvic pain. So normally regarding to the complaint, we can see that the pain, for example, does not adequately respond to treatment targeting the organ diagnosis. So that means that someone comes with bladder pain and then gets treatment or examination for the bladder, but it actually doesn't respond to treatments. Also, the pain can be associated with complaints related to function of more than one organ system. And normally the pain has direct implications on an individual's social life as work, relationships, and family. So regarding the risk assessment, but talking about the patients, normally we see in the history multiple episodes of pain in the medical history. We also see some other chronic pain diagnosis as fibromyalgia or dysmenorrhea, and also presence of somatic medically unexplained physical symptoms as tinnitus and irritable bowel syndrome. Sometimes there is more than 2 other physical complaints or conditions. We can also identify in the patient sometimes mood disorders, catastrophic or denial coping strategy, and also expectations that with symptoms will be chronic. So they say normally it won't get better and I will stay with these complaints for all my life. Also, we can do some risk assessment in the pregnancy and postpartum. So what we know is that pregnancy-related pain in the pelvic girdle and lower back pain can lead to chronic pelvic pain in 10% of the cases. So that's quite a lot. We can identify in the literature some predictive factors for chronic symptoms, including history of pelvic pain, of lower back pain before the current pregnancy, and also positive movement and pain provocation tests. On the other hand, the non-predictive factors include maternal age, the intensity of the pain, quality of life, heavy work conditions, impaired functioning, and sick leave. So talking a little bit about the role of the pelvic physiotherapist in these patients, we know that chronic pelvic pain is often associated with urological, gynecological, sexual, and corollateral dysfunctions. And this is really important to understand that when dysfunctions are present in a multiple organ system in the pelvic area, there is a high chance of pelvic floor dysfunction. So if someone comes with pain in the abdomen, but also has some urinary complaints, sexual complaints, or gastrointestinal complaints, then we can right away suspect of a pelvic floor dysfunction. So that means that early consultation with a pelvic physiotherapist is recommended when there is suspicion of myofascial dysfunction in chronic pelvic pain or when symptoms affect multiple organ systems. So that means that seeking early consultation can actually save time, improve efficiency in the care, and also provide faster relief for the patients. So we think that the pelvic physiotherapist needs to be in a team that evaluates cases of chronic pelvic pain, because sometimes there is a high chance of pelvic floor dysfunction and also dysfunction of the muscles around the pelvic floor. So what can we do? Actually, we offer a holistic approach and we address a wide range of symptoms and dysfunctions. We can offer individualized treatment plans to each patient's specific needs and circumstances. And we also can combine different therapeutic modalities for a better outcome. And we can promote a comprehensive approach for improved outcomes and patient satisfaction. So about the holistic approach, we can think about education, awareness, and functional improvements of the pelvic floor muscle, and also the entire abdominal and pelvic region. We can focus on relaxation, coordination, breathing, posture, movement patterns, and also functional restoration. And we can also think about neuromuscular reeducation, addressing urinary, bowel, menstrual, and sexual dysfunctions. And also, of course, on biofeedback, EMG, electrostimulation, also some mobilization techniques, stretching, trigger points, PTNS, and TENS. I will talk about the treatments also later, but this is just an idea about what can we do as a pelvic physiotherapist in this type of patients. So regarding the evidence, we do still need a lot of evidence regarding to the effect, the pelvic physiotherapy in these patients. But there are some evidence supporting the role of pelvic physiotherapy. There are some, I'm hurrying someone. Please turn off the mics. Can you please help me and turn off the mic from the person? Yes, thank you. So recent literature shows that pelvic physiotherapy plays a significant role in improving symptoms associated with chronic pelvic pain. And there are also some studies indicating improvements in pain, urinary symptoms, and sexual dysfunctions and anerotal dysfunctions. The evidence that exists, it's not the best regarding to the methodological quality. So we do need still a lot of evidence regarding to the pelvic physiotherapy and its benefits to chronic pelvic pain patients. Although Bergmans in 2018 highlights the clinical significant effects of pelvic physiotherapy in patients with chronic pelvic pain and sexual dysfunction, Baruka in 2016 suggests the potential positive role of pelvic physiotherapy in patients with chronic pelvic pain and also anerotal dysfunctions. And there is also a recent review of 2020 of neuromodulation such as TENS and PTNS, and this can have a positive effect also on the quality of life in men and women with chronic pelvic pain. We also have our colleague Danielle van der Rijn, die also presented some positive results with pelvic physiotherapy in the treatment of patients with chronic anal fissure. So to have an idea about what can we do for this type of patients, I'm actually going to present a case study. And I will explain a little bit what I did. This is a patient that I saw in my practice a couple of times ago. So I'm going to talk about a patient, a woman of 53 years old, with 3 pregnancies and 3 vaginal deliveries. And she was referred to the pelvic physiotherapy by the urologist. And the urologist asked for our evaluation and also treatment in case of that we found a myofascial problem in this patient. So here a little bit of her symptoms. So she presented with lower abdominal bladder pain persisting for more than 6 months. She was also having some troubles with frequency and urgency for urination. She had urinary incontinence and also recurrent UTIs, and she complained also about dyspareunia. So as we see here, we see that there are complaints in more than one domain. So we can suspect right away of a pelvic floor dysfunction with these patients. This patient has expectations about reducing in abdominal and bladder symptoms, also preventing UTIs, and she wanted the ability to engage in pain-free penetration, and these goals she would expect in 3 to 6 months. According to the patient's backgrounds and seeing the complaints, so she had lower abdominal bladder pain and recurrent UTIs for the past 5 years. She did every time treatments with antibiotics, and these were prescribed by the general practitioner and by the urologist. And she went to a variety of doctors and also pelvic physiotherapists for the last 3 years, but with limited success. And regarding to her last UTI, that was treated with antibiotics, but actually the symptoms of lower abdominal bladder pain maintain and persist since then. If you look a little bit about examinations that were done, they showed no abnormalities. She did have current medication for hypothyroidism. And she had a medical history of breast cancer in 2006 and 12 and with a mastectomy in 2012. She was a volunteer. She did volunteer work once a week and was walking and cycling 3 times a week. So she was quite active, but she was being limited because of the complaints in her lifestyle. And we will see it further. And she was experiencing quite a lot of stress due to her symptoms, and she did receive previous psychological help, but not specifically from this problem. Overall, she was healthy and she does not consume any alcohol or smokes. I tried to put the complaints in a table so that we can see more clearly. So we have pain, and the pain worsens in abdominal and bladder area, and the pain worsens with delayed voiding. And she got no pain relief after urination. She did not have pain or burning sensation during urination, and she only took paracetamol, what provided limited relief from the pain. Regarding to the urinary symptoms, she did experience an increased daytime frequency and nighttime frequency, sensation of incomplete bladder emptying, hesitancy and difficulty with urination, interrupted flow and reduced urine volume. She had moderate stress urinary incontinence, and she required 2 pads per day and rarely urge urinary incontinence. The sexual symptoms, she stopped penetration intercourse 6 months ago due to pain, and she experienced the pain superficially, but also deep pain, and the decreased sexual desire and difficulty becoming aroused in the recent years was also affecting her relationship with a partner. She didn't have any history of negative or traumatic sexual experience. And this is a question that we ask all patients that come to our practice, no matter what complaints. It's about history of a traumatic sexual experience or traumatic experience with, for example, a birth or examination with a doctor, for example. And this comes quite frequently, so be aware that this is a really important question to ask to all patients, because it can sometimes influence your evaluation or treatment plan. In her case, she did not have any gastrointestinal complaints or no lower back pain or hip complaints. So this is quite a complex case, but it could be more complex if there was also gastrointestinal and lower back complaints. So what I did was, after taking her history, I established some diagnostic goals. And there are quite a few, so I'm going to mention them. So we actually want to confirm if the pain originates from the abdomen, pelvis and pelvic floor region, and if it's related to myofascial dysfunctions. We also would like to confirm if there is presence of an increased tone of pelvic floor muscles, because we know about literature that chronic pelvic pain or pain in general can cause increased tone in muscles. We do want to exclude the involvement of the nerves in the abdominal pain, and we also want to exclude that abdominal pain does not originate from the thoracolumbar segments and L1S1. I'm not saying the diagnostic goals with a sequence, so it's not more important the ones that are on top or the ones that are low. So just see as the diagnostic goals that we set. We also want to evaluate the impact on daily activities and participation. Also understand if patient has some information about pain and how she does understand the pain. And also, of course, to assess the intensity, severity of pain and sensitization. Also assess the breathing pattern, sexual functioning, also voiding behavior and urinary symptoms, and also to confirm the presence of mixed urinary incontinence and the impact in her daily life. So after we establish the diagnosed goals, we go to the evaluation. So that we can see our instruments that we can use to prove our goals. So if we want to confirm that the pain is related to myofascial dysfunctions, we will need to investigate the tone and presence of trigger points, on the abdominal area, leg, pelvic floor area, and also on the back. We will want to do a vaginal assessment through inspection and internal palpation of the pelvic floor muscles. And we also would like to know about mobility of fascia and subcutaneous collagen. To confirm the presence of an increased tone on the pelvic floor, we will do a vaginal assessment through inspection and palpation. And we also be using myofeedback with Maple device. Exclude the involvement of the nerves on the abdominal pain. We can do that by looking at the pain location, onset and course, but also by doing neurological examination. And also to exclude that the pain originates for the thoracolumbar segments and L1, S1. We can do a range of motion assessment of the lumbar spine and thoracic spine, and also examination of the tone, trigger points, and fascial mobility. So talking about the evaluation on the impact of the daily activities, we can do the patient-specific complaints instruments. We do use this instrument quite a lot in the Netherlands to use the limitation in activity. So the patient tells us the 3 activities that are most limited because of the complaints. We can identify the insufficient understanding of the symptoms through the anamnesis. What does the patient does when he has pain? What are the coping strategies? Does she try to relax, or does she try or contracts the whole body? What does she do? Does she understand the pain mechanism around it? We will also assess the intensity of severity of pain and sensitization through the anamnesis, but also using the NPRS and also the central sensitization inventory. To assess the breathing pattern, we will use the anamnesis inspection and also mobility and trigger points of the diaphragm. The sexual functioning, we will use the FSFI and also the NPRS to have a gradation of the pain. And for the incontinence, we use the 3 incontinence questions and the PRAFAB questionnaire, and also the voiding diary and inquire and observation of the toilet posture. So we had the history of the patient, those the anamnesis, we had the diagnostic goals that we set, and we had the examination of instruments that we want to use to make our diagnose. And now I'm going to focus on the muscle tone evaluation because there is some quite things that I will talk about on this topic, and also because I can show you how you can use Maple in the diagnosis of these type of patients in chronic pelvic pain. So these were the results of the vaginal assessment through inspection and internal palpation of the pelvic floor muscles. So I felt an increased pelvic floor muscle tone. She had pain and burning sensation upon palpation, superficial and deeply. She had an increased resting tone of the pelvic floor muscles. The closure and the contraction and the urethral lift were barely palpable, and also the endurance could not be measured because I could not understand if she was able to make a contraction or not. And the relaxation seemed delayed and incomplete, but I found it really difficult to evaluate. I did find some presence of trigger points on the muscle puborectalis and pubococcygeus muscle mainly on the left side. So the question that we have to ask ourselves when we do internal palpation is the increased tone of the pelvic floor due to the contractile elements or the non-contractile elements? And I'm going to explain you why. So in normally innervated tissue with an intact central nervous system, The muscle tone is described as the resistance of the tissue to stretch and pressure or movements. So the tonus is determined by two components. The passive component that we see on the left side of the graphic, and that includes the viscoelastic elements such as fascia and connective tissue. But it's also determined by the active components, and that consists of the contractile parts, so the muscle fibers. So when we are feeling the tone with vaginal palpation, we feel the contractile elements and the non-contractile elements. But what do we know? We know that non-contractile elements are not associated with increased mg. So that means that when we do internal palpation and we feel an increased tone, this increased tone can be given through the non-contractile elements, so fascia and connective tissue, and also due to the contractile elements, so the muscle fiber. But the non-contractile elements are not associated with EMG. So that means that if we do EMG, we can actually see what is the involvement of the muscle fibers in this high tone of the pelvic floor. So if we now focus on, if we perform an EMG measurement of the pelvic floor, we are only looking at the active components. So only the contractile elements are seen on the EMG. So during a contraction, we can feel an increase on activity, and we can also measure the resting activity. Also with EMG, we can see a spasm or a cramp, and that normally gives a higher activity. Regarding to trigger points, there is at this moment no consensus on whether a trigger point can be measured using EMG or not. So because of the terminology is quite, until some years ago or last year, some colleagues still use, we used a lot in the Netherlands the term you have an overactive pelvic floor or you have an underactive pelvic floor. If you look at the terminology or the research, we see hypertonicity, overactivity, muscle tone, higher muscle tone. So we see a lot of terms, and that's quite confusing. So that's why a group of colleagues got together, and it took some years to make this report, but they published in 2021 the last review. And actually, we are now assuming another terminology. So we are now saying that there is an increased tone in the pelvic floor or decreased tone in the pelvic floor. And this is then with pelvic floor muscle assessments. Why is that? Because the overactive pelvic floor is only recommended to be used as a finding of EMG because we are measuring the contractile elements. So in this case, we see the inconsistence or elevating baseline or the slow derecruitments. And this can occur also with muscle tenderness in the diagnosis of pelvic floor tension myalgia, but is not a defining criterion. So that means, in other words, it is possible to have pelvic floor tension without increase in the EMG resting activity. And that suggests that the presence of non-contractile elements increase tone and muscle tenderness. So it's really important recognizing the proper use of the term overactive. And that may lead to more target treatment choices. So that means if we measure with vaginal palpation and we see an increased tone, we actually want to measure also with EMG to be sure that the increased tone is for contractile elements or non-contractile elements or both, so that we can also do some proper treatments. If we find a higher tone of the pelvic floor, but then we measured with EMG and we don't see a high activity at all, that means that maybe the fascia and connective tissue are causing the high tone. So we will choose as a treatment maybe more stretch techniques of the whole area, also internally, to achieve our goal. So then we can use, of course, by the EMG, the MAPLE. The MAPLE gives real-time feedback. It's also a non-invasive technique. We are able to individualize the treatments to provide patients with greater understanding on their condition and also to facilitate the participation on their own recovery. I don't know if you work already with MAPLE or not, but regarding to the interpretation, we see a grid on the evaluation, and the outer electrodes are the outer rings and the inner electrodes are the inner rings. So we are observing into the pelvic floor. We see also right, left, anterior and posterior. And we also have some information that help us to understand actually which muscles are more active. So this is the interpretation about vaginal examination. And then we can also see in this case the anal examination. So we can see actually where are the muscles that have more activity or less activity when we do the measure with MAPLE. We get the results in an absolute mode, and so that's the black and white, what we see on the left, and where the darker shades indicate higher activity and the lighter shades of gray indicate low activity. We can also see with colors, and that's the values relative to 5, they are comparing to 5 different reference groups. And that was a study that they did in initial study involving 2,029 healthy patients. And actually the white represents the average value regarding to the reference group, the blue a low value compared to the reference group, and the red a high value compared to the reference group. I must say that in the practice I focus mainly on the gray results. So on the left, the absolute mode, I find it more easy to interpretation and also to explain to the patient. We use a guideline to make all measurements. So here we can find the position of the patient, the instructions that we gave at the patient, and also how many repetitions we can use. And this is really important if we want to compare results and also to be able to do investigation. So getting back again to the results of our case study, we see now the results with MAPLE in rest. So if we look at the gray grids, what we see below, and it's in Dutch, I'm sorry, but this means average. So we see an average of 3.3 microvolts, and we think, oh, this is quite okay. But if we look at the grids, we see a darker area of gray on the left and on the anterior side. And we can see that here the activity on these muscles is increased. So if we compare to the sheet that we had before, we see that this part corresponds to the puborectalis, pubococcygeus and iliococcygeus muscle on the left side. I put it also so that you can see how it is represented with the colors and referring to the reference group. And sometimes what I also like to do is to isolate the place of higher activity to be able to see the average on this activity. So I took the electrodes out on these parts where you see the cross, and I'm now only seeing the activity on these muscles, and we see actually that the average a little bit higher is around 5.3. This is not a really big difference, but sometimes we just see, like if we isolate, that is like 10 microvolts. But in this case, it was a small difference. And we see also in the colors. So this is the line graphic that we also can see with MAPLE, and comparing to the other instruments that we used before when we didn't have the grids. When looking at the line, we will say, oh, that seems quite nice. does not present a lot of deviations and is not too high on the tone, but actually in the grid we can see where the higher activity is found. So now we are seeing the maximum voluntary contraction, and we actually see what the patient can do. And we can see on the grid that the muscle activity also comes from the same muscles. And on the rest of the grid, we don't see a lot of activity. If you compare to the reference group, it says that the activity is less lower than the reference group. And of course, if we look at the graph, we will see that the patient was almost not able of making a good contraction. And that is why also with vaginal palpation, we actually found it really difficult to conclude what we saw or we felt, because we almost didn't find any movements. That was the same with endurance. So we measured for 30 seconds contraction, and we see that the patient is able to make a small contraction, but then it loses the activity of the muscle. And when getting to the part of relaxation, we almost don't see any difference. And we see also in the grid, there is a little bit higher activation of the left side and a little bit of the anterior side, but actually the rest is quite with decreased activity. So this is the conclusion that we can take regarding to the MAPLE examination. So we do see increased resting activity on the pubococcygeus, iliococcygeus and puborectalis, mainly on the left side. We see increased also rest activity on the urogenital diaphragm, that is the anterior part on the ring 1 and 2 and 3. But we also see decreased maximum voluntary contraction and also decreased endurance of the pelvic floor muscles. So if we put side to side the results of the vaginal assessment and the MAPLE examination, we can see quite good that we did find the same. We didn't find with vaginal palpation a good contraction, but also not a good relaxation, but was difficult to understand. But also in the MAPLE, we saw precisely where the increased activity of the muscle was. Sorry. But also that was a decreased contraction and endurance of the pelvic floor muscles. So what now in this case? So it's the increased tone due to the contractile elements or non-contractile elements. I would like to hear you, but because it's a webinar, it's a little bit difficult. But actually in this case, we felt a higher tone with vaginal palpation. And when doing the MAPLE, we did find a high activity in some parts of the pelvic floor, but others no. So in this case, I do think it's a combining of both. So we do have the contractile elements and we do have the non-contractile elements that are confirming the presence of the higher tone of the pelvic floor muscles. So in this case, we can see there is overactivity of the muscles that we examined in the EMG, but there is overall a higher and increased tone on the pelvic floor muscles, and that is due to the contractile elements and non-contractile elements. So if we put the results or the diagnose everything together, we see a 53-year-old woman delivered 3 times in vaginal delivery, referred to the pelvic physiotherapist by a neurologist. And we see complaints of moderate to severe chronic pelvic pain in the lower abdomen and bladder with moderate central sensitization, frequency, urgency, urinary incontinence, UTIs, recurrent UTIs, and dyspareunia. And here are the findings. I'm not reading everything. You can read it afterwards. But these are the findings of our examination. And we see problems with the breathing, increased tone in abdominal muscles, the limitation in activities, we see urgency and frequency, We see the urinary incontinence, and the pain during intercourse was not possible to access through the SFI because, of course, she was not sexual active in the last 4 weeks. So what about the treatments? If we see the treatments, and again, here it's not set with priority, so it's not in a sequence, because if I wanted to talk about priority, maybe I would be here the whole morning. But I just set the treatment goals and what I did to reach these treatment goals. So regarding to pain education, I explained the pain mechanism and how the body processes and responds to pain. We also wanted to improve the breathing pattern and reducing abdominal tone. So we did breathing exercises, awareness, relaxation of the abdominal muscles, fascia techniques, skin rolling, and reducing trigger points on the muscles, rectus abdominis, and also the diaphragm. We, of course, wanted to reduce the voiding frequency and also improve drinking and toilet habits. So we explain how the bladder function, postponement techniques, fluid intake, bladder training, and we also used Maple to reduce urgency. And we also explain and exemplify toilet instructions. Of course, we wanted to promote relaxation and reduction of the trigger points of the pelvic floor. So we did exercise therapy focused on general relaxation and also conscious relaxation of the pelvic floor muscles. We did also some full body stretch exercises and also stretch exercises of the pelvic floor, also including internal techniques. We did myofascial release of trigger points, and we used also electrical stimulation with Maple with this goal. And of course, we wanted that the patient was able to implement relaxation of the abdominal and pelvic floor muscles in the daily activities, but also during pain moments, and also improve strength and coordination of the pelvic floor, because we did see a decreased activation of the pelvic floor muscles, and that we did pelvic floor muscle exercises and also exercise therapy with biofeedback and electrostimulation using Maple. So I resumed a little bit what I did with Maple in these patients, and of course we do need to think about this treatment was during 6 months. So it's quite, in the beginning I saw the patient more times, but then the frequency got less and less. And the priority of the treatment was treated according to the clinical reasoning and what things explain the others. This is just a resume where you can find what I used with the Maple. So we use the Maple with the increased resting activity and incomplete relaxation. So we use continuous stimulation, 15 to 20 minutes on the left and anterior, or also the ring 1 and 3. For the decreased maximum voluntary contraction and endurance, I use the contractions program, and also left and right contractions, and also the ring 5 and 6, and that I chose based on the initial evaluation. We do try the trigger points, also treatment with the Maple with continuous stimulation, 5 to 15 minutes, and this is very, I think, less than 5 minutes, it's not enough, but sometimes 15 minutes can be quite a lot also. So you do need to adjust sometimes the minutes also regarding to the patient that you have. And use also the Maple with the overactive bladder program for decreasing the urgency and frequency with continuous stimulation, 20 minutes. So I put the interval about the pulse duration and also the frequency, because we did change and were changing through the treatments, because we need to see how the patient adapts, what are our expectations, what are the results that we get. So we can vary between this interval, but we do need to see the patient and the results that we get with the patient at that time, and how the patient reacts to the electrical stimulation. So after 6 months, the abdominal and bladder pain reduced, but she was still feeling occasional pain related to increased stress and sleep disruptions. So she now could identify the factors that caused also a little bit more pain complaints. She was able to do the activities without any pain, but she did find that when the stress was higher and when that slept worse, that the complaints got back, but not so bad as before. She improved the relaxation and awareness of the pelvic floor and abdominal muscles, and we were able to reduce the frequency of urination to 12 per day, and sometimes no or 2 per night. And she didn't have any urinary infections in the last 6 months. And the urinary incontinence was resolved. The pain during intercourse, that was a goal that was not possible to reach. We also advised the patient to consult a sexologist in the treatment process, but she didn't consider like a problem that she thought that she would do it, but on a later stage. So she didn't give a lot of priority to the intercourse complaints. But this is really important to mention. The results that we get are not only results of the pelvic physiotherapy, because the patient also received treatment from a psychologist alongside the therapy. And also the patient received treatment from a pain specialist, but as the treatment progressed, the pain medication was no longer necessary. So the patient received also an extensive explanations and guidance on pain education and self-management at the hospital. So this was actually a multidisciplinary treatment, and you do need to think about a multidisciplinary approach for this type of patients. So sometimes they come to us and they are already in treatment with other professionals. Sometimes the patient comes to us and it's our role to identify to which college should the patient go. I had, for example, this week a patient that got to me referred by a gynecologist, and at the end of history taking, I thought I called the gynecologist to say, what do you think about sending this patient also to the pain clinic and also to a psychologist? So we understood that the treatment on pelvic physiotherapy was not enough, and this patient needed to be treated in a multidisciplinary team. And this also was the case that I presented today. So some take-home message. The treatment of patients with chronic pelvic pain is often complex and should always involve a multidisciplinary approach. So the close collaboration among health professional providers helps the patient feel heard and increases the chance of treatment success. The pelvic floor physical therapist plays a significant role in diagnosing, treating, and identifying issues in this multidisciplinary team. And the patient often appreciate the contact with the pelvic floor physical therapist, finding it pleasant and accessible. The holistic approach of a pelvic floor physical therapist can contribute to better outcomes. We still face some challenge, and that is that the diagnosis of chronic pelvic pain can be challenged due to the complex nature. Chronic pelvic pain is often multifactorial, involving physical, psychological, and social factors. There is still a lack of standardized treatment guidelines for chronic pelvic pain, so that's also a challenge. And effective communication between health providers and patients is crucial also to the outcomes. There is still limited access to specialized care for chronic pelvic pain, and chronic pelvic pain has a significant emotional and social impact. So we do think that an holistic approach and multidisciplinary treatment involvement are necessary for effective management. So thank you a lot for your attention. If there are some questions that you want to talk about now, maybe I can still answer them. Otherwise, I think you will put them in the chat. And the colleague also will help me to send to me the questions that are where I can find that I can answer.
So there was one question from Monica.
Yes.
To show the autonomy overview again, the slide at the beginning of the presentation.
Yes.
The anatomy of the anatomy overview.
Yes. From the first, from the pelvic floor for the muscles around it. I don't know.
Yes, I think it's one of those. I think it's this one or the earlier ones.
Let me check. So this is the pelvis. Then we started here, or we started actually here about like an